Good afternoon and welcome everybody to this webinar on lactate use in clinical practice, organized by the European Society of Intensive Care Medicine. There has been some confusion about the correct time that this webinar will start, which was due to the fact that our today's speaker is located overseas and also because of the change to the summertime. Sorry for this confusion, but I hope everyone made it in time and you are not angry about this. So my name is Thomas Scheren and I'm a professor of anesthesiology and intensive care at the University Medical Center in Groningen, which is in the Netherlands. And I'm also chair of the cardiovascular dynamics section of the ESICM. I will be moderating this webinar. During the session, if you have any question, you can pose it in the box and we will come back to it at the end after the talk, or if it's very important question, I might also ask the speaker to answer it immediately. So speaking about the speaker, today I would also like to welcome Professor Jan Bakker, who is a great expert in the field and has a large track record on the topics related to lactate. Recently, the Andromeda shock trial has been published in JAMA by his group, and I think we will hear more about this later. Professor Bakker is currently working at Columbia University in New York, but also at Erasmus University in Rotterdam and in Chile. Furthermore, he's the deputy chair of the cardiovascular dynamics section of the ESICM. So welcome, Jan, and may I hand over the microphone to give us your talk, please.
Yes, thank you, Thomas, for the introduction, and good morning for me, good afternoon to the others. We're going to spend some time on how lactate can guide resuscitation, and that's an important topic because especially in the surviving sepsis guideline, there are not many other guidelines that include lactate, but surviving sepsis guideline has a very prominent place for not only measuring lactate but also recommending a targeted change over time. And that's a very important parameter, the measurement of lactate, as for instance in the United States, if you don't comply with those parameters, you're not paid for treating the patient. So there's a very negative incentive if you don't comply to the guideline. And so lactate is in, let's say, the center of the resuscitation. But actually, I'm afraid it's a little bit more complicated than suggested. For this presentation, we have no conflict of interest. There are some companies now that are working on a more or less continuous lactate measurement device, where you have, let's say, every 5 to 10 minutes, a new lactate. We will come back to that in when we talk about delta lactate over time. Now, the interesting thing about lactate is when it was first described in 1845 by a German physicist, it was measured in patients that had just died of what we now would call septic shock. And those lactate levels were very high. And ever since that very first description, up until 2 days ago, when a paper came out about delta lactates and predictive value of lactate, ever since that time, lactate has always been associated with a worse outcome. And so if you have a patient with more or less a similar condition than the other patient, and one has increased lactate and the other one has not, the one without the lactate has always a better prognosis than the one with increased lactate. And to make it simple, this is a study done by the group in Santiago, Glenn Hernandez. And what they did is they selected patients with septic shock. And so patients with fever, a likely infection, and hypotension, they gave an initial fluid resuscitation. The hypotension did not go away, and so they required the use of vasopressors, and so the classical definition of septic shock. And then they looked at patients that had a lactate above 2.5 or less than 2.5, and you can appreciate in the slide the huge difference in mortality between these two groups. So probably we would now say that the hypotension in the sepsis group without the lactate is possibly infection-related hypotension, but not septic shock. And the sepsis 3 definitions, you now have to have increased lactate levels. Whereas the increased lactate levels with hypotension would be septic shock, and we all know mortality of septic shock is way worse than the mortality of sepsis-related hypotension, and that's basically what they show. And lactate in this group could clearly help you to discriminate the two groups. And in another recent study from Australia, they looked at patients with hyperlactatemia, so only high lactate, and patients with hypotension that did not respond to fluids. And the hypotension was defined as low systolic blood pressure or low mean arterial pressure that did not respond to a fluid challenge of at least a liter within 1 hour. And lactate was used as 4.0. That's the old surviving sepsis guideline definition of severe sepsis. And so what they did is they looked at patients with refractory hypotension, no lactate, and patients with lactate and no hypotension. And so you have isolated hypotension, 850 patients, isolated hyperlactatemia, also a large number of patients, almost 500. And then when you look at 90-day mortality, the mortality in hypotensive patients without lactate is 12%. The patient with lactate but no hypotension is almost double. And then it's very clear that if you have lactate for whatever reason, you're in a worse condition than when you have no lactate, even if you have very abnormal vital signs like, for instance, hypotension. And so the next question is, okay, that's a given lactate when you come in. What about the changes in lactate? This is a recent study where Jean-Louis Vincent from Brussels collected all the literature in which they at least measured lactate twice. And he came up with 96 studies in almost every field of critically ill patients that we see in our units. And so they found publications about general ICU populations, surgical patients, post-cardiac surgery patients, trauma patients, sepsis, cardiogenic shock, cardiac arrest, respiratory failure, and that almost covers your whole mix of ICU patients. And of course, you have different scenarios. So you have the best scenario is that you immediately start decreasing the lactate level over time, and within a given period come to an immediate normal lactate level. But some, and I think you all have this experience, you start treating the patient, and instead of decreasing a lactate, lactate goes up or doesn't change. That's a bad sign. And if you decrease lactate, then at some point it can stall for a while, so do not change much, and then it starts to decrease more, or it can even start to increase again. And all these scenarios that differ from a steady decrease to normalization, all these scenarios where you do not come to, let's say, normalization within a reasonable time. Usually we take 24 hours. I will come back to that later. But all these scenarios have a worse prognosis. And in this study, he showed that with the current evidence from these 96 studies, the reasonable time to remeasure lactate after you've taken your first measurement is about 2 to 4 hours, 1 to 2 hours. The recommendation by the Surviving Sepsis Guideline is to measure lactate every 2 to 4 hours. So that's double the time that comes from this study by Jean-Louis Vincent. And so, if measured every 1 to 2 hours, your lactate decreases, that's good. If after the first hour or the first 2 hours, your lactate has not changed or increased, something is wrong with your patient. And you should reconsider what you are doing. I will come back at the very end to give some practical guidelines. Now, the question is, do we know what to do when you come in with an increased lactate? Well, this is what we studied in this study published a few years ago, multi-center randomized study in the Netherlands. 4 centers were participating. We randomized around 400 patients, and we said, okay, in the very first hours of patients that come in with an increased lactate, we took 3.0 as a cutoff point. And in these patients, you do not have any suspicion that something else than circulatory failure is going on. For instance, if you have a patient with metformin and diabetes and increased lactate, there is a reasonable chance that the patient is not in shock. The most easiest example is patients with seizures. Patients with seizures, by definition, generate lactate, but they're not in shock. But if you think, okay, this lactate could be due to circulatory failure, I will come back later on at the end on how to do that. Then we randomized to patients where we measured an SCVO2, so the hemoglobin saturation in the vena cava superior, less than 70% or more than 70%. And the more than 70% is a marker of high flow or a distribution problem, a microcirculatory perfusion problem. And at that time, we said, okay, if the microcirculation is deranged, so you have shunting in your microcirculation, or a microcirculation is not opened up, and you get mixture of very high saturations, then in that case, we use vasodilators. And so if you came in with lactate and a high SCVO2, we made sure that your blood pressure was at least 60 with norepinephrine, and then we started a vasodilator. That's a small number of patients that come in at the very first entry into the ICU. This study started immediately on admission to the ICU. It's a very small number that come in almost completely resuscitated, but having a microcirculatory problem only. The majority of your patients, when you first see them in the first hours of septic shock, will have a low SCVO2, as was the case in the RIVER study and was the case in our patients. And so we said, if you have increased lactate, you think there is no other cause than circulatory dysfunction, your SCVO2 is low, then you have a problem in the match between the oxygen demand of the patient, of the tissues, the organs, and the oxygen delivery. So that's what you should target. And how do you target the mismatch between demand and supply? That is, decrease your demand. And so we were rigorous on treating pain, analgesia. In patients that were uncomfortable and moving around, we were easy on sedatives. If the sedatives caused respiratory depression, we put the patient on a ventilator, which gives you an additional decrease in oxygen demand. We were treating very high fevers if necessary, and if it was malignant hyperthermia, we did cooling, or hyperthermia, let's say more than 40 degrees, we did cooling. This was done in a very small number of patients, but this was a very prominent element of the manipulation of increased oxygen demand. The other element of the mismatch is improving oxygen delivery. So we had a target hemoglobin level based on the studies at that time. We had a minimal saturation, and so this made sure that we had adequate oxygen content. And then we had fluid responsiveness. Patients, and if they were fluid responsive, we said it's hypovolemia. The terminology is completely wrong because it's not really hypovolemia. It's what we would call relative hypovolemia. But if you had these conditions and you were fluid responsive, we gave fluids to try to solve the problem. If you were not fluid responsive, then we try to increase cardiac function to increase cardiac output. And for that, we usually used dobutamine or inoximab in these patients. And the aim was to increase SCVO2 to more than 70%. And that was the goal in the protocol group, to decrease your lactate. So the objective of the study was, by doing all of this, maintaining a minimal blood pressure of at least 60, by manipulating oxygen demand, by improving oxygen delivery, and improving microcirculatory perfusion, that we should decrease lactate every 2 hours by 20%. But very important, we only did this for the first 8 hours of admission. I will come back to that later. Why? So for 8 hours, so 4 measurements of lactate every 2 hours, the lactate had to decrease by 20%. If not, then we reiterated this analysis, reiterated the diagnosis, reiterated the therapy. And so what we, in a few patients, found is this was optimized, but lactate did not decrease. And then we talked to the surgeon because we thought it was an abdominal problem. We convinced the surgeons to go to the OR, or first we did a CT scan, went to the OR and found a small abscess that we couldn't find by physical exam. At that time, we didn't do POCUS, point of care ultrasound, which would by now probably be incorporated in protocols like this, especially in the emergency room. And so every 2 hours we had to check on, is the therapy adequate or do we miss something? And that's coming back to this study. So whenever this happened, we were reconsidering what's going on here. As long as the patient went this, we continued, but every time something like this happened, we reconsidered. And that for 8 hours. And we showed in this study that the mortality, ICU mortality and hospital mortality, when we corrected for baseline abnormalities, that the mortality in the lactate targeted group was 8% lower, a 20% relative reduction in hospital mortality. When together with Wan Yi from China, I did a sequential analysis of 4 trials in 2015 that were available at that time. And we looked at the 4 studies that incorporated lactate as a target of resuscitation. And we found that in those 4 studies, and we took only sepsis in these patients, the lactate study included every patient with an increased lactate. But when you look at sepsis, that was indeed a favorable outcome when you targeted lactate in patients with sepsis. And so this is where the recommendation of the Surviving Sepsis Campaign comes from. And when they quote that you should target lactate, they usually refer to the Tim Janssen study. Now, I said we targeted lactate for 8 hours. And the reason was that we suspected that in the initial hours of lactate, lactate is the consequence of abnormal tissue perfusion. Some say tissue hypoxia. I think there is a lot to say of whether tissue hypoxia is really present. But tissue perfusion, yes. And so we said we target tissue perfusion in the first 8 hours because it's extremely likely from all the experimental studies I did myself and others did, that in these early hours of sepsis you have hypoperfusion of the tissues and organs. Later on, we tested this hypothesis because we had no time to do it in the time of the lactate study. And so together with Glenn Hernandez, we looked at patients with septic shock, increased lactate levels, and we only took the survivors. So in surviving patients of septic shock, we looked at normalization of lactate, and that's what you see here. This is, let's say, the INR of lactate. And as you can appreciate in this graph, is that in the first 6 hours of these patients, the normalization was steep. There was a very fast number of patients normalizing their lactate. And then for the next 18 hours, the number of patients that normalized their lactate was very low. And at this point, almost half of the patients still had somewhat increased lactate. And so this is complicit with the time frame of the lactate study. Here you should target tissue perfusion. Is that true? Well, when we look at other parameters of tissue perfusion, you see exactly the same. So the delta PCO2, the difference between the central venous CO2 and the arterial CO2, which should be less than 6 millimeters of mercury. And if it's higher, it's indicative of abnormal tissue perfusion. If you look at this parameter, you see exactly the same. You see a very rapid normalization of the delta PCO2 in patients, just like lactate. And then for the next 18 hours, it trundles off, and a very small number of surviving patients still improve their delta PCO2. When we look at capillary refill time, which was the target parameter in the Andromeda study that I will present later, you see exactly the same. So whether you use a parameter of cardiac index, because that's what the delta PCO2 is, or a more somewhat subjective parameter that you can measure in any circumstance. You don't need central lines, you don't need arterial lines. You just have to press the finger and measure the capillary refill time. You see exactly the same. So a very steep increase in the patients normalizing the capillary refill time, a very steep increase in the number of patients improving their delta PCO2 or normalizing their delta PCO2, and this steep improvement in tissue perfusion is met by a steep number of patients normalizing their lactate levels. And so from this study, and this is the only study still available, it is clear that there is some kind of biphasic relationship in time and lactate levels. And so the question is whether you should indeed use tissue perfusion interventions beyond 6 hours. At least in this study, there is no support for that. In another study, we said, okay, let's look at lactate and let's see whether increased lactate in the presence of parameters of tissue hypoperfusion has a different outcome perspective for patients than when they don't have it. And it's basically, if you go back, you go basically back to this group versus this group. And so what we did is we studied patients that had a hypoperfusion context, and we said hypoperfusion context is a low SCVO2, increased delta PCO2, or an abnormal capillary refill time, because these are all parameters of tissue perfusion. And so if you had lactate and you had any of these parameters being abnormal, or you had lactate but all these parameters were normal, we looked at outcome. And of course, the hypoperfusion had different parameters than the non-hypoperfusion, because that was the selection. So if you had lactate in the context of a parameter that is indicative of hypoperfusion, you needed much more norepinephrine, not only in the very first hours, but also 6 hours later, and still at 24 hours. But most importantly, your mortality was higher. This was not significant. It's a very small group of patients, but you were on the ventilator for more days. You stayed in the ICU longer, and you had more rescue therapy. What they do in Santiago is, if a patient doesn't respond to the initial treatment, so vasopressors, antibiotics, fluids, dobutamine, or whatever you want to increase cardiac output, and the patient does not clearly improve, they do the high volume hemofiltration. And they do it as a rescue therapy. And so you can see, although the differences are not significant, that in all these, let's say, secondary outcomes, except for, and let's say, organ function related outcomes, these patients with hypoperfusion and lactate do worse than patients with lactate without hypoperfusion. And so, in conclusion of this part, you can say, in the early hours, if you have indications of hypoperfusion, in the lactate study, we only used SCVO2, but in this study, we also used capillary refill time or your delta PCO2. Then those patients are the worst. They have the worst prognosis. And in the lactate study, we showed that if you target this hypoperfusion with either fluids or improving cardiac output, or maybe even, if you're bold, using nitroglycerin to improve the microcirculation, that the outcome of these patients is improved. Now the question is, okay, this is clear. This is probably hypoperfusion, and we have very, let's say, efficient interventions that can deal with these problems to improve delta PCO2 and improve perfusion of organs. So the question is, as 50% of the patients that survived still had an increased lactate at 24 hours, what's going on here? Because if this is not really overt tissue hypoperfusion, what's going on? And more importantly, what is the information you as a clinician would get from this, let's say, not that fast decreasing lactate? Well, one of the elements is impaired lactate clearance. And clearance here in this study that we did in the sheep model of septic shock is real clearance. So what we did is we injected lactate and then measured the amount of lactate that disappeared over time. So that's the real lactate clearance. In the literature, lactate clearance is usually referred to as the difference between two measurements in time expressed as a percentage. So you measure on admission, you measure 2 hours later, and the change over these 2 hours is defined as clearance. That's not really clearance, because clearance in pharmacodynamics is, of course, the disappearance of a substance from the blood in this case. Now, what we showed in this very severe model of septic shock, the animals needed a lot of vasopressors to keep them stable, because it was a continuous infusion of endotoxin. As you can see, there is continuously endotoxin being infused in these animals. That makes them very sick. The lactate levels went to sky high. In many sheep, more than 9 to 10. So a very severe model of septic shock. And what you can appreciate is, here is the lactate clearance. This is baseline. And so at baseline, the sheep clear 1,000 milliliters per minute of lactate. So they clear 1,000 milliliters. That's a liter per minute of blood from lactate. And what you can appreciate here is immediately after septic shock, it's close to 0. And so in these early phases of animal septic shock, this is not what we have been able to measure in patients yet. But in these animals, there is absolutely a problem in the liver to deal with lactate. Not with sorbitol. Sorbitol is an alcohol sugar, and we did the same thing with sorbitol. And the liver is completely capable of metabolizing sorbitol, which is taken up by the liver and excreted in the bile. It has a very high first pass effect, so the liver is extremely efficient in removing sorbitol from the circulation, either in sepsis or not in sepsis. And this is not related to hepatic blood flow that we measure. We measure total hepatic blood flow. There was no change. So this is a real function abnormality of the liver, this lactate clearance. And so you can imagine that if you remove the first generator of lactate, the hypoperfusion context, then you're left with an element of abnormal clearance where lactate levels may not change at all, where perfusion is completely normal. And so at that time, and that's how I use it in clinical practice now, after 6 to 8 hours, I don't, if I have resuscitated the patient well, I come back at the end on how to use that in clinical practice, then I see lactate more as an indicator of something is wrong. And something is wrong can be metabolism, can be generation, but doesn't necessarily have to be septic shock. And here I have two, let's say, extreme examples of that. On the left is a patient with Hodgkin, with lymphoma. And we know that lymphoma has Warburg glucose metabolism. And so they mainly metabolize glucose, have no mitochondria, and so they push out a lot of lactate. And so this patient comes in, is diagnosed immediately with lymphoma and develops ARDS and is admitted to the ICU. He did not have chemotherapy yet. And so he came to the ICU, the diagnosis was already clear, we stabilized the patient, and then we started his first chemotherapy in the ICU. And this is the LDH. As you know, LDH is a marker of lymphoma, and the levels are extremely high. So this is 60, 50, 40,000. And due to the chemotherapy, this tumor was very sensitive to chemotherapy. You can see that the LDH decreases rapidly to levels less than 10,000. At the same time, he had lactate levels of 10. He was not in shock. He only had lymphoma and ARDS, but had no circulatory dysfunction. Maybe a little bit in the beginning, but we resuscitated him and optimized circulation. But his lactate levels never fell below 6. and even rose after we did the initial treatment. And at time of the start of chemotherapy, it was around 9. And as you can appreciate, together with the fall in LDH, his lactate level rapidly normalized to less than 2. And interestingly, on this day, his lactate level started to increase already before his LDH. So his LDH started to increase about here. At that time, his lactate level was back to 10. And so the indicator of recovering lymphoma cells was not LDH, but was lactate. This is metabolism. This is not shock. This is metabolism. And his lactate increased to 18 when he got his second chemotherapy, and the same thing happened. His LDH rapidly fell, and his lactate rapidly fell to 2. So here, lactate is an indicator of abnormal metabolism. The same over here. This was a patient with diabetes, and the patient had a stable circulation. He had a drain in an abscess that was not functioning very well. We told the nurses to drain, flush the abscess with at least half a liter to a liter of fluids until the fluid that came back was clear. But in the weekends, the nurses were afraid to do it because there was resistance, and sometimes the drain didn't function at all and they didn't rinse. And what you can see is that whenever the drain was malfunctioning, his lactate rapidly increased to 6, 10, together with a small increase in glucose. His glucose never was more than 11 millimoles per liter, but every time he had a surge in glucose, he had a surge in lactate. Here, 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 and here. And we tested his mitochondrial function. There was no abnormality in mitochondrial function. So this is not what Mervyn Singer from London is studying, mitochondrial dysfunction in sepsis, because we couldn't find any abnormality. The only thing we found was his abnormal glucose metabolism because of his diabetes. And so here the increases in lactates were indicative of inadequate control of the infection, inadequate source control. And so every time his lactate bumped up, we went back to the abscess and the drain and made sure the drain was open, rinsed the abscess, and then lactate would come down. And so that's, I think, a very important element of lactate as well. It's indicative of something is wrong, or maybe you're not adequately treating the patient. And so, as I said, we first did the lactate study, targeted tissue perfusion. Then we found that any parameter of tissue perfusion is a bad sign when you have lactate, including a very simple one, the capillary refill time. And so we said, let's compare the two. Let's randomize one group to lactate-targeted resuscitation, basically the standard of care now in septic shock, and in the other group, use the simple parameter of capillary refill time. And so that's what we recently reported in JAMA, the effect of a resuscitation strategy targeting peripheral perfusion using capillary refill time or lactate. And the objective for lactate was the same as in the Janssen study, so 20% decrease every 2 hours for the first 8 hours. The target for peripheral perfusion was normalizing capillary refill time to less than 3 seconds, which is a completely normal capillary refill time. And what we did in this study is we incorporated basically all recommendations that are now either more hidden in guidelines or clearly expressed in guidelines, and mainly as suggestions. And so we said, let's try to operationalize these recommendations into the protocol. And so the protocol was similar in both groups. We used the same protocol in both groups. And so either you had an abnormal capillary refill time or you had an abnormal lactate. And if the answer was no, if if you already, your first resuscitation after 2 hours, normalize your lactate or your capillary refill time, then you were done. And you would follow lactate for the 8 hours of the study. We again used 8 hours. So every 2 hours, you would reiterate this question. Is capillary refill time still normal? Is lactate still decreasing? Yes, then don't do anything, wait and see. In the capillary refill time, we used frequent assessments because capillary refill time responds very fast. You can easily assess capillary refill time every 30 minutes. For lactate, we used a recommendation from both the study from Jean-Louis Vincent and the study we did every 2 hours. And then what we did, first resolve fluid responsiveness, just like we did in the lactate study. In patients with chronic hypertension, if you didn't meet the target, then we did a vasopressor test. If you had chronic hypertension, we increased blood pressure to 80 to 85, which is, let's say, the result from the study from France. If the patient responded, then we kept the high blood pressure. If the patient did not respond, then we did an inodilator test and we used dobutamine or milrinone, whatever you wanted, to get lactate to decrease or normalize capillary refill time. If you had no chronic hypertension, you went immediately to the inodilator test after you had become fluid unresponsive. And anytime you didn't meet the goals, you went back. When you met the goals, you went back every 2 hours or 30 minutes in lactate and reiterated this to make sure that the goals were met for the full 8 hours of the study. And what we showed in this study is that that there was an improvement in survival. The p-value was 0.06 between the two groups, but the patient with the capillary refill time guided resuscitation did better. They also had a faster decrease in lactate levels, to our surprise. They also had a faster decrease in SOFA. And so secondary endpoints were better in the capillary refill time group when compared to lactate. And also, and that's what we expected, they used less fluids in the capillary refill time group. So in this study, it seemed that peripheral perfusion is even better than using lactate levels. So how to incorporate all of this into clinical practice? Now, this is what we published recently in Intensive Care Medicine. You have an abnormal lactate level. And if you think that there is a probable cause that this is not tissue perfusion, so for instance, seizures or metformin or any other intoxication, or you have a lymphoma, then, and you think, yeah, that could very well be, then act accordingly. Don't give fluids to a lymphoma patient. That won't decrease his cardiac, that won't decrease his lactate or improve his capillary refill time. Most patients with seizures don't need fluid resuscitation. But if you think that lactate is associated with tissue hypoperfusion, so there is no reasonable other cause, then look at peripheral perfusion. And you can use capillary refill time, you can feel the temperature of the skin, you can use the discoloration of the skin, the mottling. In the Andromeda, we use capillary refill time, but every parameter is appropriate. If you have normal peripheral perfusion in the presence of increased lactate, and you have normal SCVO2, that's the second step, then we would advise you to measure the delta PCO2. If the delta PCO2 is also normal, so you have lactate with normal peripheral perfusion, normal SCVO2, normal delta PCO2, remember the study on the hypoperfusion context, then probably something is wrong, but not tissue perfusion. And so probably your assessment over here was not that accurate. and you have to rethink because there is no real hypoperfusion in these patients. So remeasure lactate, make sure you have source control, make sure you have not another diagnosis and stuff like that. If you have an abnormal delta PCO2, then you have tissue hypoperfusion in the presence of normal SCVO2 and normal peripheral perfusion. That's rare, but it happens. And so you have another indicator of hypoperfusion, so treat accordingly. Increase cardiac output in these patients. And then the lactate should fall, and then you observe. If the lactate doesn't fall, then maybe you have again another source of your lactate. If peripheral perfusion or SCVO2 or even both are abnormal or low, you have tissue hypoperfusion, you should increase tissue blood flow with dobutamine fluids or whatever you want. Lactate should decrease, and I've hardly ever seen a patient that does not decrease his lactate levels in these cases. And then you observe. If lactate doesn't change, then make sure that you have a normal delta PCO2 because, again, something else is going wrong. If you have increased or normalized SCVO2, but lactate doesn't change over time, make sure your delta PCO2 is also normal. If not, increase blood flow further to make sure lactate decreases. If lactate doesn't change after you normalized everything, again, reassess the patient if you miss something. And so the complete picture is this. You start with, do you think something else is going on? No. If you have tissue perfusion, you start with the simple stuff, peripheral perfusion, SCVO2, delta PCO2, and take it from there. And if any of these is abnormal, you have hypoperfusion that we very adequately can measure and manipulate with fluids, dobutamine, inoximone, and all the other interventions that we have. So to conclude, lactate is a very strong predictor of outcome, just like changes in lactate. Therapeutic intervention that aim to decrease lactate by 20% every 2 hours for only the first 8 hours of ICU admission, both in sepsis and in patients without sepsis, are associated with improved outcome. And the early phase of decreases in lactate seem to correlate much more with tissue perfusion than anything else. And if you use capillary refill time in the latest study that we published, you're at least as effective as when you use lactate. So if you have a problem getting lactate very fast, then you can easily switch to capillary refill time to resuscitate your patient.